A very good morning, respected chairpersons, seniors, faculty, and dear friends. I'd like to start my talk with a quote from Michelle Obama. She says, "There is no limit to what we as women can accomplish." And friends, there is no limit to what we as gynecologists have accomplished and can accomplish. The talk is on management of mastalgia. One would wonder what can one do with mastalgia? Where is the need to talk about mastalgia? So we have a few objectives. Of course, the first one is to alleviate symptoms of mastalgia because breast pain is a common problem. But also, there is a hidden agenda, and that is to identify those patients who are at high risk of breast cancer so that increased surveillance can be initiated, and also to conduct appropriate investigations so as to reassure the woman that she does not have any ominous pathology in her breast, because most of the patients who come with breast pain come with an underlying fear of breast cancer. And of course, to distinguish between between benign and malignant disease of the breast. Breast pain is a common symptom. 45% of breast clinical evaluations are done for mastalgia. So we have about 45 to 50% of patients coming with pain, and we are examining them. So this is the right time to catch any pathology. Also, 15% of breast pain patients have so much severe pain that they have to disrupt their physical and social activities and take leave from work. So what are the types of mastalgia? Cyclic, non-cyclic, as well as extramammary. Cyclic mastalgia, as we all know, occurs in the luteal phase of the menstrual cycle and is relieved by the onset of menstrual flow, whereas non-cyclic mastalgia is usually unilateral, localized, constant, and the causes are inflammation of fibroadenoma or diabetic mastopathy, lesions like macrocysts, duct ectasia. Coming to extramammary pain, it is mostly due to chest wall muscular pain. It could be due to trauma. Important thing to note in extramammary pain is that even pleuritic pain or angina can mimic breast pain. So one needs to keep this in mind in the DD. And so does herpes zoster and costochondritis. Another noteworthy point is that 10% of breast cancer patients present with only one symptom, and that is pain. And they constantly keep coming back to you, pain ho raha hai, and we keep ignoring it as since we don't see a lump, we don't see a nipple discharge and things like that. Etiology is multifactorial, so the causes could be the increased estrogen during the luteal phase or hyperprolactinemia. Water retention can cause breast mastalgia. Psychoneurosis, excessive caffeine intake, smoking, aberration of lipid metabolism, GLA deficiency can all lead to mastalgia. How do we evaluate breast pain? Any patient who comes with pain in any part of the body, 4 pertinent questions should be asked: what, when, where, and how. So we ask the same questions, and the patient is advised to maintain a pain diary for 2 months so that she can actually note the dates when she has more severe pain or due to any exercise, and when she needs to take a holiday from work. And this is what we give her, a visual analog scale, so that she can assess the intensity of pain that she has. So she marks the emoji with which she relates her pain maximum. A score of 5 or more is significant and should be investigated. So we've taken the history of the complaints, and now we come to the personal history, where the amount of exercise she does, the diet that she takes, is it too much in fat, does she take excessive tea and coffee, all these things should be asked. Noteworthy is the family history. History of breast cancer in the first degree relatives should be elicited. So also history of ovarian, prostate, colon and pancreatic cancers should be asked for in first degree relatives, because these cancers come in a cluster and they share the same gene mutations. Drugs like OC pills and HRT can also cause mastalgia. So just telling her to stop these drugs can relieve her symptoms. Clinical breast examination is very important, and we do it for any kind of breast issue. So let's hear about this. Patient is examined in the sitting position, the size and shape is noted, Skin is examined for edema, orange peel appearance. Skin lesions are looked for, eczema, trauma, nipple retraction, nipple discharges looked for. Then the patient is examined in the supine position with her arms under the head. Breast is palpated in either a concentric fashion or a radial or a vertical fashion. Light, medium and deep palpation with the pads of the fingers is done. So we do a light palpation, then we do a medium type of pressure palpation, and then a deeper. And then the axillary tail is examined, then the area up till the mid axillary line is examined, and also the subcostal area. Besides the axillary lymph nodes, we must also look for supraclavicular and infraclavicular lymph nodes. Diagnosis is made by exclusion criteria. Just like we have the 3 fundamental rules to sail through life in a healthy, in a good manner, similarly we have the 3 fundamental rules to exclude breast cancer. So whenever a patient comes with any pathology of the breast, any complaint of the breast, do a clinical breast examination, advise an imaging if indicated, either a mammography, ultrasound or a MRI, and also advise a core biopsy if indicated. So once we have done all these 3 steps, then and having excluded breast cancer, we come to the treatment of mastalgia, which could be pharmacological and non-pharmacological. The non-pharmacological treatment forms the first line of treatment. So once having excluded breast cancer and other pathologies, we reassure the patient, look, you don't have any such problem. We have investigated you. We've examined you properly. Now all you need to do is take these medicines, look after your diet in such and such way, exercise and all those things which we are coming to, and also teach her about breast self-examination, and to come every year to us for clinical breast examination, mammography, etc. So she becomes a part of your clientele forever, because she needs it. And then mechanical support and non-pharmacological treatment of mastalgia is extremely important, things which we try to neglect. So a well-fitting brassiere is advised. At night, a soft supporting bra provides relief, and a sports bra for exercise. Now the definition of a well-fitting bra, we can talk about it later. Exercise. Jenk et al. Did a randomized control trial. Patients were advised the use of sports bra for mechanical support, avoidance of caffeine, simple analgesics, and an exercise program. This was more than enough to solve the problem of mastalgia. Diet is important, and a low-fi diet should be advised. Something the matter. Phytoestrogens like soya beans and tofu and peanuts should be advised, because they also cause relief in pain. So we have so many phytoestrogens. Flax seeds also provide relief in pain. Our own kalonji oil is a very good analgesic. So if applied twice daily for 2 months, Hussain et al. Found that is equally effective as is diclofenac gel. Evening primrose oil, vitamin B6 and Vitex are all important. While coming to the pharmacological treatment, NSAIDs and topical NSAIDs from the first line of treatment, we must remember that we think that these are things which can be toxic or acidic, but they are the best. Then bromocriptine, if there is hyperprolactinemia, diuretics, if water retention is there, GnRH analogs if nothing else works, and danazole should not be given, but however, if nothing else is working, it forms the third line of treatment. SERMs, most importantly, tamoxifen and centrochromin are very good drugs, and tamoxifen can be given in a dose of 20 milligrams a day for 3 to 6 months. It provides relief to mastalgia. The only side effect is that it can cause endometrial hyperplasia. Thus, centrochromin is a better drug. It is a made in India drug, and it does not cause endometrial cancer. It does not cause thromboembolic side effects, so it should be recommended, and we are proud of it. Non-cyclic pain, sometimes aspiration of macrocysts works, and of course relaxation therapy. So to conclude, rule out breast cancer by triple assessment, advise reassurance and breast support with well-fitting brassiere. NSAIDs and topical NSAIDs should be prescribed. A second line treatment if required is centrochromin or tamoxifen. Thank you so much.